Thanks all of you guys for being here, and I'm really excited to be able to talk about a topic that is near and dear to my heart. I have been an ICU nurse for, well, close to 28 years. And all of my career has been in neuro because for me, that is like the epitome of patient care. I really do enjoy the neuro patients a lot. So I'm going to share with you some information that I've gained over the years and some information for some recently published guidelines that are out there. So a little bit about the Queens Medical Center. We are a 500 plus bed facility. And I say plus because we have little extra beds here and there that we call upon as needed. We're an acute care facility. We're the only statewide level 1 trauma center. And hopefully we'll become a level 2 trauma center early this summer. And we're the only magnet facility in Hawaii. And as Kavehi mentioned earlier, we may be the first comprehensive stroke center for the state. And I say maybe because we don't have the official letter yet, but we did have a very favorable review from the Joint Commission not too long ago, back in October. We have a 34-bed med-surg/tele neuro floor and 14 neuro ICU beds, and that's a recent increase. We had 8 neuro ICU beds for 20 years. This is the 20th anniversary of neuro ICU for the state of Hawaii, and we gained an additional 6 beds this past year. We take care of severe as well as moderate TBI patients on our floors, and we have approximately 800 stroke patients that we care for each year. So things that we're going to talk about today are the principles of ICP management, the why, the what, the who, and then the how, and then focus a lot on interventions for managing ICP. So principles that are super important when it comes to managing ICP are the Monroe-Kelly Doctrine, which tells us that the brain is composed of 3 different components, and that those components need to stay constant. Otherwise, we see changes in ICP. As well as we're going to talk about cerebral compliance, cerebral perfusion pressure, and autoregulation. So Monroe-Kelly hypothesis is really the mainstay of our caring for our traumatic brain injury patients. Like I said before, the volumes in each of these components needs to stay the same, otherwise we see a change in our patients' increased intracranial pressure. So for this discussion, ICP really is a combination of the pressure within the cerebral hemispheres themselves, the pressure exerted by the blood, as well as the pressure from the cerebral spinal fluid. Cerebral compliance is the next important principle, and compliance is actually a gift that our patients give to us. The more compliant their brain is, the more likely their brain is going to be able to adapt to either changes in blood, changes in cerebral spinal fluid, or changes in the cerebrum itself. So we know we're having a great day at work when we are taking care of a patient that has quite a bit of cerebral compliance. However, your day can go really badly if you're taking care of a patient whose brain is no longer compliant. Things that change the compliance within that brain structure are the amount of tissue or blood or spinal fluid that has increased inside that cranial vault. So if it's a small amount of, say, blood, then the patients may be able to adapt to that easier than if it's, as you can imagine, a larger amount of blood. The other factor that gets involved with compliance is time, okay? So the slower that happens, a slow-growing brain tumor, as opposed to maybe a large bleed that happens immediately, affects the compliance, as well as the size of the intracranial compartment. I was very amazed to know that our brain starts to shrink at the age of 25. So most of us in here have shrinking brains, and as the brain shrinks, it allows for increased space. So if you do have some more space in your brain, your compliance curve is a bit more forgiving. So what's really cool about cerebral compliance is that you get your forgiveness here. It's not going to work on there. So as your brain is becoming less compliant and you're moving towards the right on that scale, your brain has a point reaches a point where it can no longer be forgiving for you. And that is what is measured with our increased intracranial pressure. It's at the point where the brain can no longer be so forgiving, and you actually see the increase in ICP. And that's where that ICP value of approximately 20 comes into play. So that's at the point where it's sort of like you've tipped over the edge and the brain is no longer able to be as compliant as it was before. Another principle that's really important is the cerebral perfusion pressure. CPP itself is the pressure at which the brain tissue is perfused. And I guess you guys can figure out from some of your other discussions this morning that we really need blood flow up into the brain. And that cerebral perfusion pressure that delivers the oxygen and delivers the blood flow is extremely important. CPP can be measured and calculated, and it's a reflection of our mean arterial pressure minus our ICP. So as the ICP increases and there's no change in mean arterial pressure, the CPP will decrease. And a CPP of less than 50 results in cerebral ischemia. So I think because we're all critical thinkers, we can all recognize that a CPP of 50, of greater than 50, is probably something that we're going to want for our patients in order to keep them out of that range of cerebral ischemia. Excuse me. So our fourth principle is cerebral autoregulation. And cerebral autoregulation is the ability of the blood vessel to adjust to changes in blood pressure. And this is an awesome phenomenon sort of built within our system, that our blood pressure, the diameter of our blood pressures will adjust as we need extra blood flow. And this is an awesome principle, but guess what? What happens with traumatic brain injury patients is they actually lose that ability to become to do their own autoregulation. So for us at the bedside that are taking care of patients with increased intracranial pressure, we are autoregulators for them. We do things like adjusting their CO2, increasing their oxygen, changing head of bed, and things like that that actually can help to augment that cerebral autoregulation that they have lost. So why do we manage patients' increased intracranial pressure? And we manage it because it helps us to guide decisions that we make for our patients. It allows us to identify interventions that are going to be helpful or interventions that are not helpful for our patients. It allows us to also prevent and treat any secondary brain injury that the patient may be having. The concept of increased intracranial pressure, especially if it's refractory to treatment, is a very strong predictor of mortality for patients. The higher that ICP is, and for the longer that it is, the more likely it is that our patient is not going to survive their injury. So a concept of mortality. So managing ICP is frequently necessary for our patients with severe brain injury, and identifying endpoints and goals of care that support improved outcomes is common in protocolized care such as guidelines. So one of the very important guidelines that we use to guide the interventions that we provide for our patients is the Brain Trauma Foundation guidelines. So these guidelines are actually in their 4th edition. They were just published within the last 2 months. And so there's been some updates to these guidelines from the previous 3 editions, but they are a really great subset of information from organizations such as the American Association of Neurological Surgeons, the Congress of Neurological Surgeons, as well as lots of medical and even nursing colleagues of ours that have reviewed these documents, and they've reviewed all of the literature, and they've actually given us very strong practice components for taking care of our patients with increased intracranial pressure. Well, what causes increased intracranial pressure for patients? So we talked about those 3 components that are in the brain, and it's also other things like mass lesions or vascular engorgement, brain edema, as well as contusions. All of these pathologies can contribute to increased intracranial pressure. So who should get ICP monitoring? This is one of the really great recommendations that comes out of the Brain Trauma Foundation guidelines. And they want to let us know that there are certain particular patient populations that should get ICP monitoring because it makes a difference in the patient's outcome. So they say that ICP monitoring should be done in patients that are salvageable with a traumatic brain injury. And they classify salvageable as Glasgow Coma score 3 to 8 after resuscitation efforts. and the patient has an abnormal CAT scan. So that's an important parameter here for this part of who should get ICP monitoring. Salvageable patients, they've been resuscitated and their GCS is 3 to 8, but they have an abnormal CAT scan. So things that might be seen on that CAT scan are hematomas, contusions, swelling, herniation, or compression of the basal cisterns. But there's a second group of patients that they also said should get ICP monitoring, and these are the patients where you may not see any pathology currently on CAT scan, but you know that they're likely to not do well. So their pathology may show up a little bit later. So these guys have high indication that they're not going to do well over time. And these are patients that seem to have a severe brain injury based on the clinical exam, but they have a normal CAT scan. However, things like advancing age, over the age of 40, unilateral or bilateral posturing, or systolic blood pressures less than 90. So any two of those three components means that in spite of your your normally looking CAT scan, it's likely that your patient's going to have problems with increased intracranial pressure. And so how are we going to manage that increase intracranial pressure? Well, there seems to be two buckets of ways that we monitor our patients that have increased intracranial pressure. The first is through an external ventricular drain, and the others are like bolt-like systems. So our EVDs, our external ventricular drains, are actually catheters that are able to be placed within the ventricles of the brain, usually the lateral ventricle and mainly on the non-dominant hemisphere. The really great thing about an EVD is that it allows us the opportunity to drain cerebral spinal fluid, which for those of us at the bedside that have an EVD on a severe traumatic brain injury patient, again, this is another gift because it allows us opportunity to be able to provide intervention for that patient through that EVD. The downside to an external ventricular drain is it can do one thing or the other. So it can either drain or it can provide an ICP value, but we're not able to do both. So unless we shut off the stopcock, we're not going to get a true ICP reading. So that is one of the downsides of an EVD. The bolt-like system is a great monitoring device that gives us continuous ICP, but the downside of that is you can't drain cerebral spinal fluid from that. Is inserted about 1 centimeter in depth for this system here, but we can't drain CSF, but we can get a continuous ICP monitoring reading. When we start to look into the systems that have like a catheter, a short catheter system to them, those are great ICP monitoring system because we can get the bolt reading ICP value, but we can also get brain oxygen monitoring. So these are a newer type of monitoring devices that allows us to have an additional piece of information that is extremely valuable. So as nurses at the bedside that are taking care of severe traumatic brain injury patients, to have that addition of the brain oxygen value is very important for us. We enjoy having that extra information for our patient. So invasive monitoring is used commonly to measure ICP. However, I do not want to downplay how important our clinical assessments are. Because in spite of the ICP value, what we see at the bedside is equally important when we're looking at patients having signs of increased intracranial pressure. Excuse me. So I know this is probably the audience that I don't need to read these through for, but I am going to review them with you guys because I think it's really important, especially when we talk about critical thinking, to make sure that our newer nurses, our new grads, the new people into neuro ICU really know how to recognize patients that are having increased intracranial pressure. So many times these are the patients that are just annoying to us because they are so irritable, they have such bad short-term memory, they may even become lethargic. They have a headache. They have sort of these vague symptoms that sometimes if we only think of them in isolation and don't put them together, we don't recognize clinically what is happening with the patient. So we look at early signs like headache, irritability, vomiting, photophobia. The patient that says, can you just turn the lights off because I have a really bad headache? It's like, okay, now headache, photophobia. You start putting all of that stuff together and you start to recognize that maybe the patient has increased intracranial pressure. The later signs of increased intracranial pressure are changes in level of consciousness, things like a Glasgow Coma score dropping by a couple of points. So classically, it's GCS of less than 2, or a decrease in 2. Ipsilateral increases in pupil size, shape, or responsiveness. Contralateral hemiparesis, so either a new or worsening, or contralesional change in pupil size. Ipsilateral lesional hemiparesis, or that all-dreaded Cushing's triad. So this is the patient with the widening pulse pressure, the systolics going up, the diastolics going down, the patient's becoming bradycardic, and the patient has irregular respirations. So when I'm precepting new nurses, and I always listen for that, oh my gosh, my patient's hypertensive and bradycardic, I need to treat the blood pressure. And I know for all of us that are pretty used to dealing with some new staff, this is the first thing we say is that's the last thing that you're going to do, because we recognize that that is a sign of increasing intracranial pressure when we see that Cushing's triad. So it's important to remember that the idea of ICP, while important in itself, also should be considered in the context of other factors. So other factors that influence ICP include the cerebral perfusion pressure, the CAT scan findings, the length of time that the ICP has been elevated, as well as any other accompanying pathologies or multimodality parameters, such as our brain oxygen and any other signs of brain herniation. And the critical threshold, ICP threshold, is reached when the space-occupying lesion can no longer expand without neuronal injury, herniation, and brain death. So for years and years, we have been used to treating a patient's ICP of greater than 20. So how many of you in this room, is that your gold standard, right? Treating ICPs greater than 20. So the Brain Trauma Foundation has actually challenged that. And in their new criteria, they've actually told us that an ICP threshold can be increased to 22. And I'll show you the study that actually started this discussion. So there was a study that was published in 2012 by a group in Cambridge. They looked at 459 patients from their database. So it's a 12-year database, 459 patients. And their goal was to look at ICP and cerebral perfusion pressure based on survival and functional outcome. And what they found that an ICP of 22 and a CPP of 70 was identified as prognostic for survival. In other words, we didn't have to treat at 20, but if you waited till 22, the patient still had that same level of outcome. So some facilities, as well as the Brain Trauma Foundation, have supported this change from 20 to 22 off of a single study. So I think there are some areas of the country that are trepidatious with following this new parameter, and I think a lot more research needs to be done so that we can figure out whether 22 is actually okay for our patients. So we all talk about how ICP measurement is really important, and interventions for ICP are important. However, we don't all do things the same. So there's lots of variations in how we manage ICP. Some manage patients off of millimeters of mercury, some facilities off of centimeters of water. And there was a study that was done by Dai Olson and published in 2013, where he actually had 16 U.S. medical centers report about how they manage their patients' ICPs. And we were actually one of the studies facilities that gave data for this. And I think it was 8 hours of monitoring that we actually did. So we sat in a patient's room and we measured what the nurse did and how they managed their patient. And we collected different information about physicians' orders and goals and parameters that the staff was given. And he found that across the country, across the world, and even within the same nursing units, people did things differently. So we may monitor ICP at some facilities, and others we actually monitor and treat CPP. And then some use millimeters of mercury, some use centimeters of water. Some are strict EVD facilities, and some are strict Bolt facilities, and some use combinations of both. When it comes to how high do you place your drain, that's a very controversial topic too. Some place their drains at 0, some place them at 10. Some place them at 20. It's very arbitrary. And then the other arbitrary one is, do you use your drain mostly open or mostly closed. So that is not consistent across facilities or across the U.S. And also, how long do you wait before you actually treat? Do you wait 5 minutes with an elevated ICP, or do you wait longer than that? The one thing that was pretty standard was that the nursing staff was given a goal. And the most common goal was ICP less than 20 millimeters of mercury, and the nurses were given opportunity to do what we do best and to manage that, whatever needed to be done within the patient's sphere in order to keep that ICP less than 20. So nurses were doing things like changing the environment, the temperature in the room, keeping it quiet, lower head of bed elevations, neutral neck lines, draining CSF, providing sedation, analgesics, or osmotics. But there was no standard treatment for what people were doing, so they just did what they were most comfortable with. So care for the patients was often incomplete, pretty ambiguous, and often nonspecific. So lots of variations in nursing practice, and the nurses stated that sometimes the information that's provided to them from their physician colleagues changes from day to day. And so that there was variation also within physician practices. So the conclusion from their study was there's a lack of consistency was present not only in physicians' orders, but in nurses' decisions on how to manage increased intracranial pressure. And some of those decisions would actually change from shift to shift. So how do we manage increased intracranial pressure? Well, we have about 12, 13 different ways that we manage. And even though patient management may vary, there seems to be an agreed upon set of management and interventions that are critically relevant. Some of our facilities use a tiered approach. So lower level tier, tier 0, tier baseline tend to be things that are easiest to implement, less invasive, kind of standard things like head of bed elevation, progressing all the way to interventions such as managing refractory intracranial pressure using barbiturate therapies, induced hypothermia, and maybe even surgeries. At our facility, this is the type of algorithm that we use for managing our increased intracranial pressure. It's an example, another pictorial way of displaying how to manage increased intracranial pressure, looking at options along a continuum approach rather than a hierarchical approach. This, again, also sort of expands from an easiest things all the way up to things that may be a little bit more difficult to manage. And then at the bottom, we have areas where we actually have interventions for patients that do have brain oxygen monitoring. So there's different types. You know, you see that tiered approach, you see this approach here, but it's really great when we actually have algorithms to go by, because those can be guiding principles for us, and there's less opportunity for a whole lot of variation. So things that we do need to know about caring for our traumatic brain injury / ICP patients is that there are two things that will really mess up your patient's outcome. And these are hypotension as well as hypoxia. So these are golden rules of things that you never really want to see happen for your patients. So not just pre-hospital, but also, or I should say not just in the hospital, but these are also pre-hospital concepts that can lead to secondary brain injury. And what's interesting about these guys is that independently they contribute to an increased morbidity and mortality. So hypotension is bad, hypoxia is bad, hypotension and hypoxia, real bad. So we are given these goals that we want to maintain for our patients. And for the longest time, systolic blood pressure of 90 was the gold standard for blood pressure that we did not want to see. We wanted to see our patient have, right? So something greater than 90. But the new parameters that are being advocated by the Brain Trauma Foundation actually is for a patient's systolic blood pressure of greater than 100. And that is for patients that are in the 50 to 69-year-old age group. So that's sort of the midlife age group. However, if you look at patients that are younger or patients that are older, they're now advocating for an systolic blood pressure that is greater than 110. So some new recommendations from them. And then hypoxia is super important. Again, we talked about how important oxygen is, but keeping in mind that hypoxia can actually cause the patient to become ischemic within their brain, and then they're not going to get enough cerebral blood flow. So hypoxia is super important. So how do we manage oxygen and perfusion of that brain within our ICU? Well, again, it's with goals and interventions that we look at for helping to achieve that oxygenation level. We want an oxygen sat that is greater than 90. We want a PaO2 of 80 to 120. And a PCO2 that is 35 to 45. Now, PCO2 of 35 to 45 is probably extremely important because we don't want the patient to have a CO2 that is too low, because a low CO2 will decrease our cerebral blood flow and contributes to the patient having cerebral ischemia. And we don't want a CO2 that is too high, because the CO2 that is too high contributes to cerebral hyperemia, and that will cause and contribute to increased intracranial pressure. So CO2 is one of those just right kind of concepts, and that patients really have a decent cerebral blood flow if you're looking at a normal CO2 of around 30 to 40 or 30 to 35 to 45. So things that we do for our patients is we encourage that there be an early airway. Many of our patients that have traumatic brain injury are going to require some sort of airway assistance. Our goals for us at the bedside are also to prevent hypoxia and to make sure that that CO2 level stays within a normal range and that we are not hyperventilating our patient or causing a CO2 that is too low. Because of too low of a CO2, remember, causes cerebral ischemia, which contributes to poor outcomes. Hey, come back. So conclusion is that normal ventilation with the PaCO2 of about 35 to 45 is recommended, and prolonged prophylactic hyperventilation with a PaCO2 of less than 25 is not recommended. And that will come up again later in the discussion. So as a nurse, we do a lot of ET tube suctioning, right? And so we think patient has ICP 16, 18, 20, patient seems like they need to be suctioned. Am I going to cause more harm to my patient by actually suctioning them? And I know in my early phases of taking care of brain injured patients, I was sort of reluctant to do suctioning because I didn't want to cause any additional harm to the patient. So a few studies have been published looking at ET tube suctioning and its effect on ICP. So a study that was published in 1992 by Crosby and Parsons showed that 2 passes of a suction catheter does have a negative effect on not only ICP but mean arterial pressure and CPP, and it takes about 2 minutes for the patients to return to baseline. Dai Olson also reported again in 2013 that when he monitored 54 patients during suctioning, it did not result in an increase in ICP in 91 of the patients that they monitored. And then a meta-analysis that was published in 2009 recommends that if you're going to suction patients, use short duration of hyperventilation, so a little bit hyperventilation prior to suctioning, and then continue to avoid that routine hyperventilation. So what we would say about endotracheal suctioning is that ICP does increase associated with suctioning, tracheal stimulation, as well as coughing, but the increase in ICP is modest and transient. So it's an okay thing to do. So what about chest PT? Because sometimes that can actually look like that's going to contribute more to increase intracranial pressure than just a general suctioning. So a randomized observational study was done to explore the effects of chest PT on ICP. And this was a multi-center study, 30 patients from 3 hospitals. And they did 10 minutes they had a baseline ICP, 10 minutes of chest percussion, followed by 60 minutes of observation of the patient's intracranial pressure. And their chest PT was actually done through the bed modules. So some of us may have those modules in our bed. So that was one way of being able to standardize the type of chest PT that was done. And they recorded the ICP every minute. So their baseline ICP was 13.94. The mean ICP during chest PT was 14.38. And the mean ICP after was actually lower than what they started with. So it was 13.7. So the conclusion from their study is that chest PT appears to be safe option for patients with ICP monitoring. So what about positioning? We position our patients often, and head of bed elevation of 30 degrees seems to be what what is utilized most often. So head of bed elevation is thought to decrease ICP by displacing cerebral spinal fluid into the spinal canal and improving cerebral venous drainage. And multiple studies and guidelines promote head of bed elevation to decrease ICP. So 30 degrees seems to be the magic number. If the patient has spinal cord injury and it's very difficult to raise just the head of bed, then you can actually use reverse Trendelenburg. Other positioning interventions that work well are keeping the head in neutral position and loosening the cervical collar if it's too tight. But one of the things you really need to be careful of with head of bed elevation is that, again, this is where you have that sweet spot, because patients in our ICU, especially those that are on bed rest, especially those that are getting interventions for ICP management, have probably experienced some diuresis. They may be slightly dehydrated and their intravascular volume may not be very strong. So what happens when you raise the head of the bed either too much or too fast? Their blood pressure goes down. So you're actually causing more harm to the patient if the blood pressure goes down the same time the head of the bed goes up. So 30 seems to be sort of a sweet spot where you don't get too much hemodynamic instability. So 2 studies that were done that looked at our cervical collars and then our head elevation and how that impacts ICP. So a study that was published in 2002 looked at our rigid cervical collar and looked at articles that had been published with what happens to our ICP during that rigid collar. And they said that the collar acts like a tourniquet around the patient, and there is impedance of venous drainage, which will cause the patient's ICP to increase. So their recommendation was to make clearance of that cervical collar a priority. Don't leave the collar on too long, and don't let it be too tight, because it does give that tourniquet effect. The other study that was published was looking at the ICPs of patients who had their head turned. So these were during surgery. So these were patients that were going in for elective brain tumor surgery, and they did ICPs before and after induction of the anesthesia. So when they turned the head, 60-degree rotation, the ICP increased, but then when they elevated the head of the bed, so the first head turn was with the patient flat, and then when they elevated the head of the bed, even with the head turned, the ICP reduced. And they found that patients reported headaches with head rotation when their ICP went up. So kind of interesting. So the other study is looking at backrest elevation and how that changes not only intracranial pressure but CPP. So Karen March published back in 1990 a study that she did small study, 4 patients, and looking at 4 patients and how their ICP changed when the patients were positioned from flat to head of the bed at 30, head of the bed at 30 with knee gach, or patients that were placed in reverse Trendelenburg. And she compared the effects of ICP, cerebral perfusion pressure, and transcranial Doppler studies. And she found that position changes were variable. Position changes that were variable caused a variable increase intracranial pressure, even within the same patient. So it wasn't always consistent with how the patient was going to respond, and it definitely was inconsistent between patients. But she did find that CPP measured at the brain rather than at the phlebistostatic axis was more sensitive to position changes. And so conclusion from these studies is that all TBI patients should have head of bed at approximately 30 to reduce cerebral edema and support venous drainage. So activities and stimulation, nursing activities that impact the patient's ICP. So 1993, a published study was done looking at the effect of nursing activities on 5 brain-injured patients. And they monitored ICP before, during, and after turning, suctioning, and bathing. And they found that turning and suctioning raised the patient's intracranial pressure, but it was not a sustained raise in intracranial pressure. But what they found was that there's a lot of clustered nursing activities, and we tend to not do one thing and let the patient rest and another thing and let the patient rest. We accumulate a lot of our activities together. But once rest was achieved for the patient, the ICP actually came down. So this other study that was published looked at 9 brain-injured patients and also did bedside observation, looking at the effects of ET tube manipulation, respiratory care, repositioning, range of motion, as well as invasive measures like IV insertions and IM injections. And they also found that there was a mean increase in ICP of 10 to 12 millimeters of mercury. But again, with rest, that elevation came down. So what about oral care and ICP? I hear that often. They say, well, I don't want to brush the patient's teeth, or I don't want to do oral care because I'm afraid that the ICP is going to increase. So in the 1980s, 4 studies that were published showed that ICP elevations occur amongst a cluster of routine nursing activities. But when Virginia Pendergrass published 2 studies in 2009 as well as 2011 looking at just the impact of oral care. So the first study that she published in 2009 showed that there was no negative impact on ICP when oral care was performed for 45 NSICU patients. So then in 2011, she published a randomized controlled trial where she looked at the difference between manual toothbrushing and electric toothbrushing. And she showed that ICP increased by 1.7 millimeters of mercury during oral care with either manual or electric toothbrushing, but it came down to 2.1. So again, this is the second study that we saw that the ICP transiently increased, but actually went down further than what it was prior to the intervention. And she found that there was no difference in groups on whether on her pre and her post patient evaluations. So in conclusion, oral care, providing oral care to patients at risk for increased ICP is a safe intervention, and we get a mild, non-risky, transient elevation in ICP. So what about sedation and pain relief? So brain injury patients in the ICU are known to experience more significant pain than initially presumed. Studies that have been published recently show that it is very common for patients to have pain, and it's not only underreported, but it is undertreated. Things that are commonly used are anesthetics, analgesics, and other sedation medication that we give our patients to control increased intracranial pressure. And a lot of times this pain management aspect of our nursing role is very individualized, and it's very different from nurse to nurse. Our perception is not always the same on whether or not the patient's having pain. So it's great if the patient can report through self-reporting, but not all of our patients can do that. However, we don't give them the opportunity sometimes. So it is really important to be able to try to get that numeric self-report if possible. When using medications, we try to balance the difference between over-sedating and then under-sedating so that the patient is experiencing pain. So we use more short-acting agents like fentanyl, propofol, and Versed. Sedation itself can be a little bit more challenging because we don't know how to screen out the difference between the patient's neurological change and whether we've over-sedated them. So many times we try to keep that balance between not over-sedating the patients. And there are some technologies that can help us with that. So BIS monitoring is a type of a monitor that we use to be able to monitor our patient's sedation. So it's a 0 to 100 scale, where 0 being way too much sedation and 100 is a wide awake patient. We tend to target our BIS value of around 40 for patients where there's optimal sedation. So some of the studies that have been recently reported do not recommend that we do sedation interruption or sedation wake-up in patients that are having intracranial hypertension. I think that's a little different from our colleagues that work in the SICU and the MICU. But it is detrimental to our patients to have ICP elevation. We have them on optimal sedation, and then we just shut it off and actually watch to see what happens with our patients. So that escalation in ICP that you get after you turn off their sedation or their pain medication can actually worsen the ICP afterwards. So it is not recommended. However, prioritizing pain and sedation management is very important, and nurses need to balance obtaining that neuro exam with the over and under sedation, and I think that's something that we do an awesome job with in balancing that. In Society for Critical Care Medicine guidelines, really recommend that we use their PAD guidelines for pain and sedation management. So their PAD guidelines are the pain, agitation, and delirium assessments. The delirium assessment that is supported by the SCCM, being the CAM ICU, assessment is not the best assessment for our neuro patients. So it can be a little bit complicated when we start trying to compare patients that are in the neuro ICU versus patients that are in the other ICUs. So hyperosmolar agents, commonly used for managing intracranial pressure. They've been used for many years. And there's two different agents that are used. Mannitol probably being the most common one that's been around for a long time. Rapid IV bolus, effect in 15 to 30 minutes, max effect in about 30 minutes. And the total effect for mannitol lasts around 4 to 6 hours, hence like the 6-hour dosing. However, patients can get easily dehydrated. We have to monitor the osmolar gap, and it becomes less effective with repeated doses over time. And there is an eventual diuretic effect with mannitol. So hypertonic saline came onto the scene. It's one of the recent newer players when it comes to hyperosmolar agents. And what's nice about hypertonic saline is we have different concentrations. You have lower concentrations of 0.1 all the way up to 30%. And with hypertonic saline, we have different options for how to provide that, whether it's continuous, whether it's bolusing, and it can be given more often than mannitol. So we use it interchangeably with mannitol, especially for patients that have high osmolar gaps. And the nice thing about hypertonic saline is there are less hemodynamic effects and less diuresis with the hypertonic saline. So 2 studies that have been published recently look at the effectiveness of mannitol versus hypertonic saline. The first study that was published in 2014 is a retrospective study, 73 patients, that showed that hypertonic saline was more effective in lowering the ICP burden. However, the 2-week mortality was not statistically significant when looking at the difference between these two treatments. A study that was published in 2011 was a randomized control trial for 47 patients and also showed no statistically significant difference in the average time with elevated ICP or Glasgow Coma score at 6 months for either of these treatment options. So the conclusion is that hyperosmolar therapy using either mannitol or hypertonic saline has been shown to be beneficial in reducing both cerebral edema and increased intracranial pressure. So what about CSF diversion, our friend, the external ventricular drain? So an EVD in a closed position allows for monitoring of intracranial pressure, while in an open position, it allows for drainage of the cerebral spinal fluid. And practice patterns are different, as we talked about earlier. So some facilities use the open system and some use the closed system. But regardless, the EVD is seen as a therapy that is quite effective. So an EVD system zeroed at the midbrain with continuous drainage of CSF may be considered for patients with severe brain injury in order to lower the ICP burden more effectively than intermittent. So providing continuous drainage for the patient can actually get us more therapy at our goals than just doing intermittent. So preventing cerebral ischemia, cerebral perfusion pressure, calculation of our mean arterial pressure minus our ICP, and we talked earlier about maintaining our MAP. And our MAP goal for patients in order to have a better outcome is approximately 60 to 70. Oh, sorry. So what's great about mean arterial pressure is it really gives us an indication of how well our patient's brain is being perfused. But if we use aggressive measures to keep the CPP elevated, we can actually cause our patients to have more harm. So things like pulmonary edema, things like ARDS, if we use lots of extra fluids or vasopressor management to push our patient's CPP to that higher level. So caution in what else is going on with the patient. Another intervention for us is maintaining normothermia. So fever worsens outcome after brain injury. And I think for all of us that work with brain injured patients, that has been drilled into our head for the last 15, 20 years since it's become in vogue to take care of our patients' temperatures. The current emphasis is on maintaining normothermia for patients. We don't always have to induce hypothermia, but maintain normothermia because increases in temperature cause increased in O2 demand, and all of that will increase our cerebral blood flow, which in turn increases our intracranial pressure. But what we found, again, through surveying staff across the nation is that we have different definitions of fever that we treat. So some people treat 38, some people treat 38.5, but so our fever definitions change. But we do know through some of the studies that have been done that our brain temperature will elevate before the patient's core temperature or even their, especially if you're measuring temperature through a Foley system. We use medications like Tylenol, either PO Tylenol or right now, IV Tylenol is a very effective medication. We cool patients by using iced IV fluids, cooling blankets, external cooling as well as invasive cooling, and most important is to be able to manage the shivering. So hyperthermia is associated with increased length of stay, higher mortality, and larger infarct size. And nurses are key players in choosing interventions from tepid baths to cooling devices. So a few years back, one of my colleagues and I put together this evidence-based practice algorithm looking at managing normothermia. So we call this our Normothermia for Neuroprotection Management guideline, and it actually looks at strategies from managing the patient in the preventive phase. So this is a patient with a slight temperature elevation of greater than 37, and looking at environmental management, things like cooling the room, adjusting thermostats, administering Tylenol, or providing cool baths for the patients. Interventions in that therapeutic phase, so when the temperature gets greater than 38, we start surface cooling, and then maybe even add some IV Tylenol at this point if necessary. And then when the patients are in the refractory phase, temperature is greater than 38, that's when we pull out the bigger guns and we start looking at considering intravascular cooling. But anytime you're cooling patients, you have to manage their shivering because that becomes a problem too. So we do have an algorithm that we use, or a guideline, I should say, that we use for managing shivering. Shivering is complicated. Shivering is counterproductive if you're trying to manage your patient's fever. So very important that shivering is managed through whatever sedation medications are available to you for managing shivering. So refractory management of increased intracranial pressure is really where we go on a different tier therapy when everything else is not working. So we start to feel very maxed out. So things like Barbituate Coma, inducing hypothermia, very important. So barb comas are used to decrease the metabolic rate. We use medications like Pentabarb, about 5 to 10 milligrams per kilo, followed by a drip, and our dose is based on EEG burst suppression patterns. The thing about Pentabarb is it's got lots of side effects, so we need to understand those side effects. We need to understand all of the systemic effects that will happen. All right, I'll go through it. Just a couple more slides left. The thing about Pentabarb is it has a long half-life, and then again, many of those side effects. So Pentabarb will lower ICP even when other treatments have failed, but risks to other body systems is quite substantial. Inducing hypothermia works. It protects the patient's brain tissue. It decreases their increased intracranial pressure, but just like Pentabarb, there are a lot of side effects to hypothermia. And we're not receiving a lot of positive studies from hypothermia management because we're not all doing it the same. So lots of unresolved issues with managing patients by inducing hypothermia, but what we do know is that most data supports that induced hypothermia is effective in reducing increased intracranial pressure. Hyperventilation, I said earlier that we don't do it, but we can actually do it on a very temporary measure. So this is where we would hyperventilate the patient to a CO2 less than 25, and I think of it as a way of managing the patient as we're heading to the OR. So it's not a therapy that we really want to do for any prolonged period of time, but when we know we're on our way to the OR, it can be a useful intervention. Decompressive craniectomies, doing surgery on patients that have high increased intracranial pressure must be done early and must be done large enough. So conclusion is that decompressive craniectomies will reduce ICP and minimize days in the ICU. However, the data does not always support improved patient outcome. So a couple of conclusion slides. Caring for patients with increased ICP is challenging, rewarding, and frequently full of surprises. And as RNs, we are committed to providing excellent care to the population of patients and families that we serve. We commit ourselves to healthy relationships with our patients, our families, and our colleagues, and in order to fulfill the mission and vision of the Queens Medical Center. I'm really proud to say that I work in a facility that is mission-driven. We were founded by King Kamehameha and Queen Emma, and the mission at the medical center is to fulfill the intent of Queen Emma and King Kamehameha IV to provide in perpetuity quality healthcare services to improve the well-being of Native Hawaiians and all the people of Hawaii. And so that's why what we do every day. And the vision for the Queens Medical Center is to be the preeminent healthcare system of the Pacific, providing superior patient care that is continually advanced through education and research. And thank you.